Hello, Vlad. Hello, how you doing? Can you hear me? Can anybody hear me? Does anybody really care? Hey, Vlad, you're muted. Okay, well, we'll talk later. We start in about 28 minutes.
Good morning, John.
Hold on. Yeah, how you doing? Abalash, you remember how to screen share and everything, right?
I have not done the screen share yet.
Okay, let's do it now.
Yeah.
You want me to show you first?
Sure.
Okay, hold on. First, you start by going on the bottom of your screen. Yeah, how you doing? Hold on. Abalash, you remember how to screen share and everything, right?
I have not done the screen share yet.
Okay, let's do it now. Okay, you go to the bottom of the screen, there's a share screen icon. Do you see that?
Yes.
Okay, don't do anything. I'm clicking that and 6 screens are opening and I pick the one I want to go to and then go from there. Then I own the screen. I can go to a PowerPoint, I can go to a website.
Actually, it's open on my desktop. I have not closed it, so.
Okay, try it now.
I'm going to click on my slides and I'm going to share with you.
Okay. There you go. Okay, you got the screen there. Just adjust the size.
Okay, so now I can just go at my own pace here.
Yeah. Try to make, okay, there you go. Perfect. Okay, you know how to go forward and back, right?
Yes,
Okay, now do you have any videos?
I do.
Okay, do they have sound or no sound?
No sound. I'm going to
Okay,
be narrating.
Okay, good. Okay. You want to check on them, make sure they open okay? Are they
Sure.
incorporated in the presentation?
Yes, let me go to one of them right now.
Let's check them.
Okay, can you see my
Yeah, it's perfect.
Can you see my finger?
Let me see. Yeah.
Even better.
Yeah, that's good. Yeah.
Oh, I was very apprehensive that this would not work.
Okay, it's working fine. And you can actually, well, I don't know if you want to mess with it now, but you can actually make that hand bigger if you go into the settings, but that's fine. That's fine the way
No, I
it
think
is
this
now.
is fine.
Yeah, we don't want to mess with it at this late hour.
Yeah. John, you've given me a lot of confidence now to tackle my worst IT fears.
Yeah. Well, you just make mistakes. That's all. So what? So what? You
Yeah,
just go, okay, I made a mistake.
It's one thing making mistakes, but making it in front of a live audience is a whole different thing.
Oh, I know, man. I've made some really boo-boos. Real boo-boos. Turned the sound of video off for 15 minutes. The
Yeah.
audience was sitting there and there was no sound for 15 minutes. I didn't even know it.
John, you're a busy man. You're up at all time zones. You work.
Well, it's crazy hours because you're dealing with India and Africa and their times different. Their work time's different.
Yeah.
And you got to hit them when they're working. But I got plenty. I got sleep, got naps. But in medicine, you begin to appreciate just a couple of hours of sleep.
Yeah.
Just a couple of hours for me is fine. I feel good. Of course, most people wouldn't understand that. They think that's kind of crazy, which it probably is, but I function fine. Just
Oh,
click,
good for you.
getting 2 and 3 hours. Now, you know how to get off the screen there, right?
Yeah, I'm going to go back to my initial screen, and then I'm just going to
Yeah,
keep it open so we can just keep.
Okay, you know how to leave the screen share?
I'm
At the very-
up top. I see a stop
Yeah,
share
yeah,
button.
yeah, stop share. Yeah, stop share, because when I'm gonna introduce you first.
Okay. I'll leave the screen open like this for now.
No, for now, okay, but when I introduce you, you have to get off it.
Okay.
Okay.
I mean, go to the slide play mode. You mean?
Yeah, best just to get off it totally, just leave screen. You don't feel confident? I think you can do it again. You don't feel like you can do it again?
Right there.
But we can't see your face when I introduce you.
Oh, got it. So
You know what I mean? So just get
but
off it totally.
yeah,
Just
there you go.
leave it totally. You'll be able to do it again.
Can you see my face now, or?
No, you're just like a little guy in the corner. So that's not the way to do it.
Oh,
You just leave the screen share totally.
oh, stop share. Got it.
There you go. Yeah, we got 12 minutes anyways. Okay, I got to do some last minute stuff, okay?
Okay, good.
Como conferenza sai nella come mai so ma inglese moza ngobungo soski take kulo sin so ya vasko ngoti ngaizha ngamala 3 jours nam napanda ngaluke nesiji confine no mundo e goma ivi dinga kiri répondre par vidéoconférence sasa ndakatsinda kabisa oplitar le ndinga wana hika ya kemloza mamwaye ngefranga takotari shwanga jazwenu na bado kulonga transport nije kisha tunaija tanye de confine que confine mega mala tumadalo Bonjour, bonjour, bonjour à tout le monde.
Oh, good. Hello, everyone.
Hello.
Hi, how are you?
Fine.
Good.
It's a
Where are
great
you?
time.
Where are you from, Khalid?
I am working in Saudi Arabia, but I'm Egyptian.
Oh, okay. Marhaba.
Hello.
Yes, marhaba.
Great.
Yes, Arabic shway shway, yeah.
Yeah, that's great, really. This shwaya shwaya is enough nowadays.
Yeah, it works for everything.
Yeah, little. Shwaya means a little, and it just worked.
That's fantastic. Well, thanks for coming over.
Thank you very much.
Your, what is your practice like where you are?
Yeah, our hospital is too much involved in the trauma.
Yeah.
Very busy trauma center. So around 60-70% of our work is cranial and spinal trauma.
Wow.
Yeah, a lot of trauma we have, really.
What kind of trauma? Is it mostly motor vehicle accidents, or is it?
Yeah, most of the trauma, maybe more than 90%, motor vehicle accidents. Saudi Arabia is I think it has maybe the highest motor vehicle accident all over the world. Maybe
Wow.
I think it's very here they are speedy most of the time.
Huh.
You know, wide roads, thousands of kilometers, new cars. That's all.
Yeah, yeah, and plus you don't have the changes in temperature like rain and snow, so the roads are probably.
No. It's almost all same all over the year. There's no much difference.
Well,
Sometimes in what should be considered as winter, temperature may reach 20 or something like that. So otherwise, most of the time it is 40 plus.
okay, so it's very, very, very hot.
Yes,
overall.
it's very hot.
Okay, excuse me, gentlemen, we're about to start, okay? You ready, Abadash?
That's
Yeah, I'm ready.
great.
Okay, 10, 9,
Yeah,
8,
sure.
7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett. I can't go to this beach. We got the quarantine, but we have the pleasure today of having Abalash Haradas, a pediatric neurosurgeon from Tampa. And I'll let him launch right into his presentation. Good morning, Abalash.
Morning, John. Thank you. Thank you, Hira, for all organizing this. I'm going to share my screen. Okay, here we go. So I'm in Tampa. We're going to be talking about moya moya. We'll jump right into it. So moya moya is a progressive stenosis of the intracranial internal carotid arteries and their proximal branches. The incidence is slightly higher in the Japanese population, but it's also quite common in many other parts of the world, including the Mediterranean. When you have moya moya, it can be idiopathic in many cases, but there are also many conditions that are associated with moya moya. And these are a list of the conditions. Here, NF1, sickle cell, and Down syndrome are probably the three most commonest reasons to have moya moya. I'm not saying every patient who has these conditions will develop moya moya, but when you see these patients in your clinic, you should have a slightly higher suspicion, especially if they come in with stroke-like symptoms, that moya moya is a possible diagnosis. Some of the ones on the bottom are more, they can be associated, but they're not as common conditions. One thing over here, postcranial radiation. We know radiation can cause alterations in blood flow, and if someone has had radiation, especially brain tumors as children, and they've had multiple radiations over their lifetime, they can develop moya moya. So just something to think about. Now, what happens in moya moya? It's not, it's where there's a hyperplasia of the smooth muscle that occurs here. And this causes the blood to, this impedes the blood flow, causing the stroke to happen. Sickle cell disease is a slightly different it's an inherited condition that can lead to moyamoya, and it can cause multiple problems with the blood flow in various parts of the body, the lung being one of the most commonest in the bone. But when they happen in the brain, they can lead to strokes, and bone marrow transplant has emerged as a very potential cure for some of these debilitating diseases. Specifically with sickle cell disease, transcranial Dopplers can be done on a 6-month or yearly basis. And when you have an increase in velocity, you have almost a 40% chance, especially when your velocities are over 200 centimeters a second. So sometimes we use this when we are talking to patients and what their stroke risk is. The important thing about the asymptomatic patient, what do you do when someone really doesn't have a stroke, but they've been diagnosed with moyamoya? There's no real clear screening guidelines. You have to really probably watch those patients a little bit more closely and give them reassurance initially. And you may or may not want to treat them with aspirin or even refer them to a hematologist for further workup. But a majority of the patients with sickle cell disease will have radiographic progression of their moyamoya. Now, radiographic progression does not mean that they will have symptoms. So it's very clear to make that distinction. Only about 10% of patients will have symptoms. So this is called the IV sign, where you have these flare. This is a flare study showing the T2 hyperintensity around the sulcus, and this is usually a very good sign to look for if someone is potentially going to have a stroke. The Suzuki grading system, I'm not going to go into detail, but this is an angiographic evaluation for moyamoya, and now a more updated Berlin grading. You can read this in a stroke paper from a couple of years ago, where they've looked at MR perfusion studies to grade moyamoya. So this is a more updated and recent grading system. So, of course, whenever these patients come in before surgery, doing a good preoperative assessment is important, because you need to ensure that they don't have a stroke or a hemorrhage post-op and you've lost function. And it's also good to keep track of your outcomes moving forward. Neuropsychology assessment, MRA, angiogram. You can also get a cerebral angiogram in these cases, or just a plain MRA if the patient cannot tolerate a cerebral angiogram. SPECT studies, these are not done in all cases all over the world, but many centers do perform this on a regular basis. And if you're dealing with sickle cell kids in particular, they should get transfusions preferably within a few days of their surgery being done. So the types of MRAs are different in different institutions. It depends on what kind of machine you have, if you have a Hitachi or a Philips. And this is a time-resolved MRA where you can see it catches the arterial and venous phase quite well. And sometimes this is all you need to give you the diagnosis of moyamoya, and you can move forward with treatment. This is an example of an axial view of an MRA showing complete occlusion of the carotids bilaterally. This patient does not have the lenticulostriate hyperintensity or vessels that you would normally see. So this is a very late stage moyamoya. This is an example of what the IV sign looks like. I mentioned earlier, where you have the flare changes on both sides of a sulcus. So this designates patients that are slightly higher risk of developing strokes. And in this angiogram, you can see the vessels, the puff of smoke vessels. That is classically, that's exactly what moyamoya means in Japanese, puff of smoke. So what are we really trying to achieve? We're trying to prevent thrombosis, prevent a stroke. So you want to keep these patients very well hydrated. And if they have preoperative symptoms such as headaches or seizures, you want to address that and see if you can mitigate those symptoms with medication prior to even considering any surgery. So surgery is really not the first option. You want to try to see if you can control their symptoms and wait till they develop a worsening of symptoms. So when I think about these cases, especially you have to take a step back and not think of this as moya moya, but think of the entire philosophy of this talk is flow. You are trying to get flow to the brain where the brain needs it. So how do you get flow there? Sometimes you have a stenosis of the carotid in the neck and you have to replace flow to the entire brain. You open up flow in the neck and that happens. If you have a big aneurysm, your goal there is to replace the entire flow to that hemisphere if you're going to take the aneurysm and take the carotid. So that's called a flow replacement. In moya moya, it's flow augmentation. It's very different. Flow augmentation means you're just promoting, you're trying to create a way for the brain to get blood through alternate means. So you're not replacing it completely, but over time, the flow will increase. So it's a much more gradual process and it takes time. So you have to first identify what your goals of treatment are. So moya moya is a flow augmentation procedure. It is not a flow replacement procedure. So very important to have that very clear understanding and tell the patients that very clearly when you speak with them, because they may feel the same after surgery, and that's okay. But they will definitely notice some improvement, especially in their cognitive skills or memory. I've had many patients, especially with their memory, improve over time. So that's really what we're going for. That's a goal. It's a long-term goal, not the immediate effect that we're looking for. So before surgery, you should have very clear conversations with your anesthesiologist. I maintain normal carbia, normal thermia. At all costs, you want to avoid hypotension. That is a bad situation. And of course, controlling your blood loss. So these are not very bloody cases, but with bad technique, you can lose a lot of blood. Aspirin is continued, is started well before surgery, and it's one of the few surgeries where we actually continue it. We don't stop it. If a patient has forgotten his dose of aspirin, you can give it to him per oral, or you can give it per rectal, 325, and that's completely acceptable. The fluids are kept at 1.5 to 1.25 of maintenance, and this is maintained for about 2 days post-op. And I usually start it the day before surgery. In some centers, you would have to admit the patient prior to surgery, but this is also important when it comes to getting patients well hydrated so they tolerate the surgery well. Pain control, this is more of an issue with children. When they wake up from surgery and they are in pain, they can hyperventilate, and that can cause vasoconstriction, and your bypass can potentially have the chance of failing. So it's something that is not really a surgeon's fault, but it's also paying attention to what happens in the perioperative period is just as important as your surgery. And in general, I use absorbable sutures on the younger children just because I'm tired of hearing them scream when you take them out. So over the years, I've just resorted to this. It's a much more bearable for both the doctor and the patient. So this is a paper from 2008, Dr. Charbel, Dr. Hanjani, and the team at Chicago. I had the honor and pleasure of training under him, and he's taught me bypass surgery when I was a fellow with him. And they developed this concept of cut flow index, where I will show you where we do this in one of the videos coming up, where when you cut the superficial temporal artery, you measure the flow within the superficial temporal artery. And after your bypass to your middle cerebral artery, you divide these two numbers and you get an index. If your index is over 0.5, then there's a likelihood that your bypass is going to have a very good long-term patency rate. And if your cut flow index is under 0.5, then you have developed a potential error. And these are the type of errors you can get. First and foremost, poor indication. You probably didn't think, you probably falsely assumed the patient had moya moya and you thought a bypass would help. So sometimes these are things we learn in retrospect, like many things in medicine. It's very evident now in the time of COVID, how many things we're learning on the fly. We have a lot of things we understand about moya moya, but sometimes you wonder, why did my patient have a stroke in spite of having a flawless surgery, or why did they have a hemorrhage? And the type 2 errors are mostly technical problems where you may have a problem with the donor. Your vessel is a problem. You may have a problem with the anastomosis where you do not put enough stitches or there's bleeding from the anastomosis. And the third issue is the recipient. The recipient may not be healthy, and I'll show you one example of that, one of the videos coming up. So positioning. When you position the patient, I've seen this surgery performed by multiple surgeons, and usually we are, you can put the patient in pins, the Sugita clamp or the Mayfield clamp. But if you notice here, this patient, this is the right cheek, this is the right ear. This is a view from the back. And this is the outline of the superficial temporal artery. And this patient is laying on just a foam donut. And usually I put a small shoulder bump underneath the ipsilateral shoulder to just give the neck some relaxation. So there's no restriction of venous outflow. And these are small but subtle points to keep in mind, because they will not only keep the patient and your anesthesiologist happy, but also it gives you the comfort you need to do this. Remember, this surgery takes some time. So the more comfortable you are, the most likely you're going to have very good success with your bypass strategy and skills. So this is something it's not something people tell you, but when you hear it once, hopefully it'll take effect. So this girl had a craniopharyngioma many years ago and had multiple bouts of very strong radiation. She fortunately did not have a recurrence 10 years later, but you can see the scar from her bifrontal craniotomy. But she developed severe moya on that side, and that's the reason why we did this surgery. So that's the reason why when you want to avoid neck rotation, you want to use the clamp. I don't use the clamp because I worry about injuring the contralateral STA or posterior auricular artery in case the patient is bilateral. And if the patient has had surgery on the prior side, I worry that I may injure that craniotomy no matter how many years it's been. So it's more of a philosophical approach I have, but there's nothing wrong if you pin the patient. So I just want to make that very clear. And if you're going to pin the patient, be very careful of where the pins go so you don't injure the contralateral STA. You may need that in the future, so don't burn all your bridges. So options, direct and indirect bypass. This slide alone, we can talk for a couple hours, because this debate is as interesting as it's like talking about clipping and coiling and having a debate about it. But it's important to be flexible. In pediatric patients, generally indirect bypass is preferred. In adult patients, direct bypass is preferred. And if you have the ability to do both, that is some of the more recent literature, especially out of Berlin. You can read there's a stroke paper from Wykowski and colleagues in 2018 and published in Stroke, where they showed a benefit, especially in all age groups, for patients that have had both have had the direct and the indirect bypass, and because the direct bypass over time gives you very, very a good augmentation of blood flow to the hemisphere that's involved. Now, when you look at the superficial temporal artery, it's a terminal branch of the external carotid artery, and you can see here this is the internal maxillary artery, and that it's not shown on this video on this picture, but the middle meningeal artery comes pretty much in this location and makes a slight hairpin turn on your angiogram. So that's how you identify the middle meningeal artery. So you don't want to confuse that for your superficial temporal artery, which is roughly about 1 centimeter away. So it's important to just have that concept. Sometimes you can, it's always a good idea to have a very good working relationship with your, if you're not an endovascular person and you don't see these scans or angiograms that much, just have a conversation with them. There's a lot of anatomy you can learn just by looking at these scans. This is the superficial temporal artery parietal branch and frontal branch. And this is the bifurcation can be very close to the zygomatic root. or it can be also slightly higher. And sometimes you only have one branch and you don't have the other branch. So all multiple things. Sometimes the frontal branch can come up and split posteriorly into larger branches. So you can take one vessel and multiply it by 3 and then to 3 bypasses. So these are all things to really consider. So just like any neurosurgical procedure you do, anatomy is the foundation of everything that we do in surgery. So the more you repeat the anatomy, just like surgery, you'll get better at it. And you want to confirm your anatomical knowledge during surgery and have an aha moment if you say, oh yeah, I knew that extra branch was going to be there. So I'm going to show these, I'm going through these slides just to give you some pointers, but I'm going to reiterate it during the videos so you'll have a very clear understanding. You always want to dissect along the vessel when you're taking out the STA. You want to dissect parallel to the vessel. You want to go along the vessel, because if you go beside the vessel, you can tear off the branches, and that can make your feel blooding, and potentially you can injure the superficial temporal artery. If you're using a bovie to cauterize, make sure it's on a very low setting, around 8 or 10, and use a Colorado tip, which is a needle point. Don't use a broad tip, because you want to be very, very fine. You're not painting it with a brush. You're doing very fine strokes right over the vessel. Extremely important. And I'm telling you this because I've injured the vessel, and it's very, very disheartening when that happens. And it's purely technique. So very important to keep that in mind. Doppler frequently. If you're beginning to do this, use your Doppler. Don't be shy. Just if you hear it, then you can see it, and then you proceed forward. I start usually distally in the head and then go proximal. You can start in the middle and go that way too, but I like to go distal and work my way proximal. And you can use skin markings. You can mark directly over the skin, and you should not use any injection or use local anesthesia, because you can obviously injure the superficial temporal artery, which is your friend in this case, and not your foe. So this is a video. I'm going to go through this to give you those steps. This is a young boy. He's about just under 2 years. You can see we're out. This is the right side. We're outlining the frontal branch of the superficial temporal artery and then the parietal branch. You can see there's a branch coming up here. This is just outlining the parietal branch over and I used this to plan my craniotomy. He had both ACA and MCA territory infarctions, and this is under the microscope. I do the dissection under the microscope. This is a technique I learned from Professor Tanikawa in Sapporo, who was a fantastic vascular surgeon. And you can see the superficial temporal artery coming into view and going right next to it, and then bipolaring it and basically moving it away from the vessel. This is the other technique where you use a bovie and you come directly over the vessel. The reason you want it under a low setting is because if you have it under a high setting, it'll transmit through your mosquito into the vessel and damage the vessel. That's why you want it at a low setting. And now we have exposed the STA. We slowly start to come posteriorly. Again, this is going right next to the vessel. Take your time. You want to use your bipolar carefully. You don't want to just burn everything, because if you burn everything, you're basically burning the skin edges, and you will have a postoperative infection or wound breakdown. This is a rule for any neurosurgical case, but even more important with these cases. Respect the tissues, and they will respect you back. So once this is done, you can release it, the STA. You can see this in my left hand is a atraumatic forceps. So if someone gives you a tooth forceps, just happened before, please don't use it because you will damage the vessel. And now we have harvested the STA. So now we are extending our incision anteriorly up to widow's peak. And these are just Raney clips to control bleeding. And this is now bringing your musculocutaneous flap anteriorly. These are fish hooks. And now I'm protecting the STA under and posteriorly, and both branches have been harvested, okay? Now this is a young child, so you can see the temporalis muscle is very thin. I saved this temporalis muscle for the end of the case to promote the indirect bypass, which is the myosynangiosis. I'm making a burr hole. You can see that skull is very, very thin. Be careful here. This is where your bypass, your vessels are. So you see my drill is very close to it. I would definitely have someone protect the vessel so you don't catch the vessel in your drill. Drills are very good, but they're also very dangerous in the wrong area. These are dural tack-up sutures to prevent any epidural bleeding. And now we are opening the dura. The dura is opened, is tailored. You don't, if the patient has, this is the dura being flipped underneath to promote the indirect bypass. And here I'm trying to preserve the middle meningeal artery. And again, making a triangle around there to promote the indirect bypass. Now, this is the frontal branch that we are seeing now. When you, it's the same technique. You can use a scissor. I'm showing you all these different techniques because you develop your style. You don't have to do it this way all the time, but whatever works fastest, and you have to be efficient. You don't want to spend all day doing this because you still have to do the bypass, which is going to take more of your attention and your energy. So try to be as efficient in this part of the case, but be safe also. Now, once the vessel is harvested, it is very important to, again, this is all done under the microscope. So you should have very clear understanding of the anatomy. This is taking the adventitia off of the vessel, have an assistant hold it to give you some counter traction. A lot of irrigation. You can see the irrigation coming on. We're using a pen just to mark it, and then of course fish mouthing it. Try to be very gentle with the tips. This is a 27 gauge needle to infuse the interior of the vessel with a heparinized saline, about 10 units per ml. Now we have both vessels exposed. Now the dura has been opened. Taking out the arachnoid is important. This is just a piece of glove. The glove that you use, just use that. There's other multiple materials that can be used, but I found this it's cheap and you can use it pretty much anytime. Some people don't even use a rubber dam. So again, be flexible. That is the thing with bypass surgery. Just do what you feel comfortable. But these are just to tell you there are options you have. This is isolating an M4 branch on the cortical surface. Now this is 11 blade. You can use something smaller like a needle and make your opening in the vessel. And now we're doing the heel and toe stitch. This is the toe stitch. This is a 10-0 needle, BV75-3. I'll show you that in one of the slides coming up. And once you do the heel and toe stitch, you can tie this down. And again, I use the microscope and do this under high magnification. And I also use the foot pedal and the mouth switch. This is purely something habitual. If you enjoy using the mouth switch, go ahead. But if you don't, then please don't. Maybe it's not what you're comfortable with. When you get bleeding like this after the bypass, that's actually a good sign. That means there's blood flowing through there. It's better than having no flow, but it can be very easily controlled with just some irrigation. And then you can see this has you're taking off the final clip, and this should have like the appearance of either like a cobra head or like an elephant's paw. You pick your analogy. And that's kind of what we are looking for. Now, similarly, we picked this is an AVM clip, again, opening up. You can see the vessel is very, very translucent. When you're doing this maneuver with the scissor, don't be aggressive, because if you push too hard, you can go right through the back wall. And I've seen salvage techniques for that, but trust me, it just adds another potentially 10, 15 minutes of pain in your life. And it makes you probably a little bit more tired, and you want to kind of get through these cases and have good outcomes and move on to the next case. So again, like a cobra head appearance, and then we're checking this with the Charbel flow probe. I did not show you the cut flow measurements, but this is how it's done. This is an ICG run. I'm going to show you, this is the flow going into ICG, and then I'm massaging the other one to see if the flow comes through. So let me go back a second. Yeah, so this is where we take off the temporalis muscle and we suture it directly to the inferior part of the right. This is the right side, right ear is here. And we use that to do the indirect bypass. So this is the EDAMS portion. Make sure you have a generous opening, especially in the temporal part. That will be where your bypass comes in. And because this is a young child, I use sutures to close. And of course, standard skin closure. And I leave a drain almost always to very low suction. So I'm going to be showing you some more videos coming up, but just want to reiterate, aspirin is kept the whole time. We don't stop it. You want to maintain the fluids at 1.5 or 1.25 maintenance. If you have an elderly person with some mild congestive heart failure, better not to drown them with fluid prior to surgery. That's not a good idea. So use your judgment. Again, study your patient and explain to them why you're doing what you're doing. And everyone gets an arterial line, Foley catheter. These are not very bloody cases. These are not cases where you lose and you need to give transfusions. Unless, if that's happening, then your technique is off. You should not be losing a ton of blood, especially with moya bypass. They're supposed to be very clean cases. And it's not like tackling an AVM where you can have these swings and ebbs and flows. So, and definitely no local anesthesia. I put up this slide to just give you an idea of how the people have asked me many times, how much do you give? Depends. If I take care of children and adults with moya, so if you have a child, you want to use 10 per kg of aspirin, or if an adult, you can use baby aspirin, even 325. Heparinized saline, you can have your pharmacist make this the day prior or the morning of, and make sure it's 10 units per ml, have a ½ liter bag hanging somewhere. So you have free access to it during the entire case. Papaverin, it comes, at least in the USA, it comes in 60 milligram in a 2 ml vial. And you want that diluted in about 40 cc's of saline. And bolus the patient with Keppra or fosphenytoin to make sure they don't have seizures post-op. Just like anything in neurosurgery, your skill is only as good as your efficiency in using the tools. This is from Dr. Shaker's paper in 2007. This is a flexible suction. You can put that in multiple areas. This is more useful, these long instruments, for deeper bypasses. If you're planning to go doing like a P2 or a STA M2 bypass for an aneurysm. But for moya, you're mostly working on the surface. You don't need long instruments. So have short instruments. That's what I prefer. I think if the closer you are to the field, the more stability you have in your hand. When you make your anastomosis cut, and you'll see this in the upcoming video, you want to make it at a 60-degree angle and have it about 3.5 times the width of the vessel that you're anastomosing to. The instruments you use are extremely important, like I mentioned earlier, but also the suture. I use the 75-3. You can also use a 9-0 BV104. These are very fine sutures, and they're also expensive. So you want to really try to utilize the suture to its maximum and not waste it. These can easily go up your suction when you're suctioning, so it's very common to lose them during the case. These are the Kamiyama scissors. This is from the Mizuho. This is I forget which company, but these are all like diamond coated, and this gives you the grip you need to hold your needle and give you the dexterity and the agility to do these bypasses very, very clean and efficiently. This is a demonstration of indirect bypass, where we make a temporal craniotomy and we just find the STA, we leave it in continuity, and we directly place it. This is the dura open. You can see the middle meningeal artery branches on the dural surface. This is just some Surgicel. Again, you want a nice clean feel. And once the dura is open, we lay it directly onto the pia, and then use a teno suture to directly suture it. The best place to suture it is right where the arachnoid meets the pia, the arachnoid pia interface. That's where the arachnoid is more tough. You don't want to suture it on the arachnoid over a vessel. That's where it thins out. This way your vessel will actually lay down where it's supposed to lay down, and not just bounce back up once you're done putting your stitch in. So you want to find that it'll be pretty obvious when you grab it with your instrument where it is stable and where it's not. And then just putting gel foam on both sides to cover the rest of the brain, and the bone is replaced back. This is what it looks like on ICG, and this is what it looks like on a TRIX image, where you can see the direct bypass going directly to an M4 vessel, and very good. This is some more TRIX imaging showing that. Sometimes patients have had surgery before. They've had surgery 10 years ago. Now they have another stroke. So, sometimes it could be poor technique from the prior surgery, or it could just be that their disease is just progressing at a rapid pace, and you have to help these patients, because ultimately your goal of surgery is to avoid them from getting more strokes. And every stroke, any stroke is a bad stroke. I don't care how you slice it. So you can use burr holes as a salvage therapy, 1 to 24 per hemisphere, and this can be one way of handling it. And if you've had a patient omental transposition, I don't have any experience with this, but this has been reported in the literature, where you can take omentum and do a flap on top of the brain. But these are obviously very advanced cases that have failed all therapies. If you endovascular therapy is not very effective in moya moya, and if you look, there's been a recent paper from a few years ago out of San Francisco, where they looked at the trends of bypass surgery in the United States, and for aneurysms and ICA occlusion, the numbers have gone down, but for moya moya, it's gone up. So this is one of those things where this is really one of the disease conditions where bypass has really shined and continues to shine. And I think the results that are being published all over the world are a testament to how, if you do good surgery for moya moya, patients do very well, and they'll respond to your surgery. Now, complications, you can have reperfusion injury, bleeding, of course, any part of the brain. Bypass occlusion, this is, again, it can be technical, or it could be like the type 1 and type 2 I showed you before. It could be because maybe the brain doesn't need the bypass at this point, and then it'll occlude. And then if you have bad technique, or if there's your bypass occludes, you can have up to a 7 to 8% stroke rate. So don't be afraid of complications. If you're tackling these cases, you have to look at yourself in the mirror and share your experience with people, so they don't make the same mistake. And this is an example of a young man, a teenager who has sickle cell disease, and he was undergoing. He had undergone he's being treated for bone marrow transplant. So he was on rejection medication. You can see those are extremely strong medications. He's very immunosuppressed. He developed moya moya. He had a stroke. We did his surgery. Surgery went fine, but several weeks later, you can see he broke apart. And this is taken care of by a simple revision. The important thing is don't try to say, oh, that'll get better. Let's check out in a week, because in 2 weeks this may be double the size, and now you won't be in a position to just oppose the skin edges. And in that case, you have to potentially talk to your plastic surgery colleagues. The patient may be a candidate for a flap. So these are things just to think about, because when you have a complication, that's okay. It's how you handle the complication that's important. So that is going to be what guides you through these tough times. And you can talk to your friends, of course, and get some advice if you're in tough. This case, I mean, I can go on with how many mistakes I see here, but you can see the 2 aneurysm clips here, and these small branch. I was trying to use this clip to block that off so it doesn't. And you can see there's a gel foam where it's lying down like a head on a pillow. And I'm trying to bring my bypass graft in, and this is sitting there, and I'm like, oh, I want to get that out of the way. And the minute I move it, you see how it changes. All of a sudden, it's blood. It's just blood. Very frustrating. Obviously, I used the wrong clip, but then you can see the corridor. I'm working between these 2 clips, and I kept thinking to myself, why would I do that? Why I should have made that a lot wider. And also, to make things worse, this patient's middle cerebral artery recipient was very poor quality. I sensed that even before cutting the vessel. So again, in retrospect, I probably would not have done bypass to that. I probably would have looked for a different recipient. So that's what I learned from this case. The patient did fine, but it just goes to show when these things happen, especially during surgery, you're by yourself or with your partner. Yeah, you know, this is you know, this is not Who Wants to Be a Millionaire where you can call your friend. You have to figure it out and fix the problem and take care of things. So this is a left craniotomy in a young kid with moya moya. We used both branches are identified. Again, this is the technique to harvest the STA using, I'm using the microscope here. You can see it moving. This is the frontal STA. One point I forgot to mention, when you're harvesting the STA, use a pen and mark the top of the dorsal surface of the vessel, like here. This way it doesn't twist. Because after your bypass, if your bypass twists, you're failed. So, and this is filling it up. It just fills up like an anaconda with heparinized saline. And here we're preserving the middle meningeal artery. I've kept the parietal branch in situ. And using very fine, pick up the arachnoid and cut the arachnoid. This is the recipient vessel that we're seeing here. Cut the arachnoid very carefully. Take your time, very gentle movements. Spend a lot of time here. You want to create a nice white background so you can have the contrast, and take the adventitia very, very cleanly and safely. And you'll see my assistant is completely irrigating the field. It has to be wet, and that glistening adventitia will come into view, and it has a slightly purplish color. This vessel is about 1 millimeter wide. I think we're measuring it. Yeah, we're measuring it. You can see it's about 1 millimeter wide. Find your recipient right here. You can see, compared to the last slide, you can see how there's much more length here. So just, you know, you do your heel stitch and toe stitch. I've isolated the arteriotomy. And this is a standard 11 blade. If you're not comfortable, you can use a 25 gauge needle. And then there's also pot scissors to do this, but I used to use a micro scissor. And you can see this is now the toe stitch going in. It's a 10-0 needle. And once you get that stitch in, you have to start, I do an interrupted suture on both sides. Theoretically, these tend to grow over time as opposed to continuous. And if you have made a mistake with interrupted suture, you can always take it out. And you can see how I'm lifting up the edge here. You want to get the adventitia, the intimal layers opposed like this, not like this. And make the tail of your suture small so it's easier to tie. You don't want to go up and down on the field. You want to be as close to the vessel so you can and tie it and stay in one area. You can see all the actions taken care of right next to the vessel. And you can see there's multiple sutures on either side of the vessel, about 8 to 9. And then once this is done, I like to zoom out with the foot pedal and then zoom back in. This way, because you're working under very high magnification, you don't want to injure something on the way in. And then once you're done with your bypass, you can see it's pumping away. That's a good sign. But just because it's pumping doesn't mean that it's flowing. You have to check it. And this is the inside to one. You can see the flow is going through very well. And in this ICG, you can also see the different stitches, the little black dots where the stitches are. And that's the rest of the video. The other vessel, we used it for a indirect bypass. So with bypass surgery, patient selection is paramount. Please plan accordingly. Whenever I plan these surgeries, these are elective cases, I am never on call the night before. So there's no way I'm waking up in the middle of the night doing a hemicraniectomy or decompression or taking out a clot and then coming back 3 hours later to a bypass because you're tired. So you have to be very well rested and plan these cases as your day goes, and pick your team. Just as you notice, there's so many steps in these surgeries, and just as you get better, your team will get better. So try to find a few people that you want to. It's not like you're doing hundreds of these surgeries a year, so you want to have very good results. So pick a team and then keep it consistent, so your results also stay consistent. And remember, flow augmentation is a goal. You are not replacing flow here; you're augmenting it. So use your judgment. Don't be enamored by direct, indirect. They all work. but it's what works best in your hands. The direct bypass will give you immediate reperfusion, and it has been shown to increase the cerebral blood flow and vasoreactivity over time. And so that's why I've done both for pretty much all my patients over the last several years. And dedicate time for training. You can go to a lab, you can do this with a chicken wing vessel, but use a microscope and try to find, if you finished a bypass surgery, you have leftover needles, don't throw it away, recycle it, take it back to the lab, practice. And soon you'll be able to do these one-hand stands and have some food like these guys here for fun, and then you'll enjoy it. So, but the journey can be a little arduous, but trust me, it's very gratifying when this cases go well, and especially when the patients do very well. So thank you everyone for listening. Please, this time, stay safe and healthy, and I'll take your questions if you have any.
Okay, thank you very much, Abhilash. Excellent. And we have a lot of panelists here today, so we'll open it up for questions. If your internet connection is not great, you can text questions in the chat box. And so the floor is open. Hopefully we use this to interact, this platform. I'll get you off, Abhilash. I'll get you off the screen share. Okay. Let me just. Okay. Very good. Okay, the floor is open.
I have access to the, you can even type in your question if you have it. I can see the questions.
Go ahead, Daddy.
Yeah. Yeah, Dr.
Thank you, Haridas. I really appreciated your demonstrations. I don't do a lot of bypass here, basically because of resource challenges.
That's
Fukushima,
Nigeria, right? Nigeria, right?
Yes, Fukushima taught me a lot of bypass techniques when I had fellowship with him, but it's been a bit difficult. Then you have to have good patient selection before one begins to go at that. But when they present late and then patients are not financially, up to it, then it becomes difficult to do those things. Thank you very much. And on a lighter note, you said you can't phone a friend. Sometimes you might need to phone a friend if you yeah.
Very true.
If you run into trouble, sometimes an extra hand may just help. Thank you very much.
Thank you. Thank you, Dr. Kane, for your comments, and appreciate it. I think with these cases, you have to keep an open mind, and I completely agree. Many places do it very differently, and but at the same time, ultimately, if as long as the goal is the same, like we are all here to learn, it doesn't matter how you approach it, as long as your intention is very clear, and of course, most importantly, the patient does well. So thank you for your comments. There's one question here about from Dr. Siddharth Agarwal regarding the cut flow index. So the cut flow index, I didn't highlight it here for time, but basically when you have the STA, the initial step is you have to have the Charbel flow probe. So you have to have that in your hospital. And this probe will measure the flow within the vessel of the cut STA. So that's number one. Number two, once you're done with your bypass, you measure flow through your bypass, and then you divide those two numbers, and that gives you the index. So if you have an index over 0.5, that's excellent. So if your bypass, when you cut it, is supplying 10 cc's per minute, and after your bypass, it's providing 10 cc's per minute, that's an index of 1, which means that your patency is going to be, your bypass is going to survive based on the literature on cut flow index. Now, I'm not saying that every surgeon uses the cut flow index, but if you have this ability, this is just another parameter you can use to highlight validity in your cases. and also to give you confidence that your bypass is most likely going to stand the test of time. Now, of course, if your bypass fails over time, you can always look retrospectively and see and question the cut flow index, or find out if your technique was bad, but that comes under the type 2 error.
Okay. More comments, questions?
Yes, there's a question from Dr. Haroon. If the M4, I mean, the question is about M4, so we're talking about the recipient vessel. One very important point, which I didn't mention in my talk, is in Moya Moya, splitting the Sylvian fissure is probably one of the most difficult, it's probably one of the most difficult Sylvian splits to do, and I highly recommended not doing it. So if you're going to look for a vessel, look for an M4 vessel, at most an M3. Do not go to the M2. I have personally not done that, but because the brain is not a normal brain. It's a brain that has misery perfusion, and it's very hyperemic. So if you try to dissect to the fissure, you may have bleeding all over the place, and then it'll be very discouraging. So if your M4 recipient doesn't look healthy, definitely do an EDAS. Or you can just lay your vessel directly on the brain and do a PL synangiosis. So it's very important. Sometimes I keep both vessels in continuity, identify my recipient before cutting it. So these are all different ways you will develop after your first couple. You'll see, you'll start to look at the nuances a little bit more closely. That's at least what happened to me. You can look at videos all you want, but once you start doing these cases, you realize there's a lot that comes out from serendipity, or just from operating on a regular basis. And of course, when the bypass takes, it's very reassuring. Now, with another thing with the M4, don't be. You can look at your M4 vessels on your preoperative angiogram or your CTA, and use that as a guide. Sometimes the M4 and the veins look the same. They both look red. This is another trick. If your M4 vessel and your vein looks red, you're going to be thinking, which one do I isolate? You don't want anestomos to a vein. So in that case, do an ICG run. And the arteries will light up first, followed by the veins. So that's a little trick. Or you can try to use a Doppler, but I found ICG very, very helpful. It's one of the few times where I actually give ICG before the bypass. And that's one thing. So another question from Dinuj45 is, what precautions will you take while doing, what is the different indication for high flow and low flow bypass? Excellent question. So the key word in that question is flow. Flow, flow, flow. The goal of surgery is to promote flow. In Moya Moya, the goal is almost always low flow bypass. We are looking for just augmenting flow. We're not trying to replace the flow for the entire hemisphere. The time you use a high flow bypass is if you're going to sacrifice, you're doing a huge MC aneurysm and you want to proximally occlude or isolate the aneurysm, or if you are doing a retrograde thrombosis of the aneurysm, that's where the high flow bypass comes in. I have some videos of that, which is obviously not this talk, but very, very different pathology. That is not Moya Moya. So that's where you use a high flow bypass. So it's very, very distinct for that category of patients. Moya Moya is an augmentation procedure. You're augmenting flow. Augmenting does not mean replacing completely. So a low flow bypass is all you need. That's why sometimes all you need is muscle. You don't have to go, and if you're not comfortable doing a direct bypass, if that's not within your armamentarium. Thank you from Bangladesh. Nice.
Okay,
What should be done accidentally if we end up doing complete arteriotomy recipient vessel? Excellent question. So I have not encountered this myself, but I've seen it happen to someone else. And I'll tell you, it is really hard, because when you make first of all, the M4 can be a millimeter, maybe 0.8 millimeters. But if you have a 2 millimeter M4 recipient and you make an opening in the back, other way around it. You can't put Surgisil, you can't put gel foam. You definitely should not fill it with anything. So you should put a stitch in it, but and keep it very, very, you definitely use a 10-0. And that's how I would fix it. Do you use contralateral STA if ipsilateral side is not available? I have not used the contralateral STA or attempted a of course, with contralateral STA, what comes to my mind is the Bonnet bypass, which Dr. Bashkaya gave a fantastic presentation. If any of you missed it, you should watch it from a few weeks ago with the Bonnet bypass. But no, I think in that case, I would tell the patient that we will just do an indirect bypass. You can potentially also see if the posterior auricular artery is available. We don't talk about that much, but that's behind the ear, and see if you can flip it anterior to help you with this. So these are the different tricks.
Okay, I wonder if Dr. Goel, are you there? If he'd like to comment. He may have stepped away. Okay, the floor is open for anyone else that wants to say hello or just ask a pointed question or comment.
John?
Oh, go today, Dr. Well, how are you doing today?
Very well, John. Nice to see you and great presentation, Abhilash.
Thank you, sir.
Moya is indeed quite an issue, and there are various issues, and what you suggested is the key word is the flow. Flow is not there, and you have to introduce the flow. That is the key word. And how you introduce that flow is by various maneuvers, as you have suggested. I'm also studying this subject for quite some time, and I'm having a little bit of an alternative viewpoint, which I will discuss maybe after 1 year or 2 years, because I'm still developing this concept of a little different viewpoint. So I don't want to disturb you too much in the current, whatever you are saying, but you are, indeed, you have shown some beautiful bypasses and beautiful basic things in this. And I wish you all the best, dear Abhilash.
Thank you, Professor Goel. Always a pleasure and honor speaking with you.
Thank you. Thank you, Abhilash.
Thank you. We'll be going on to Dr. Goel in a few minutes. Any more questions or comments from the panelists? Don't be afraid. It's a tool to have interaction. That's the best part about it. People are quiet today, Dr. Goel.
Yeah.
Okay, I guess we'll move on. Thank you very much, Abhilash, and we look forward to having more presentations from you in the future.
Thank you, John.
Okay, very good. So we'll move on to Dr. Goel. Welcome, Dr. Goel. It's all yours.
Okay, John. So do you see my slides, John?
Yes, yeah, excellent, excellent.
Abhilash, do you see my slides?
Yes, sir, I see them.
Are you surprised by the title?
Divine. The spelling
Divine.
is
Yeah.
unusual spelling.
Divine.
Yes.
Divine is wrong spelling, you think? Divine.
Yeah.
Well, what's the context?
Okay, now you will see. You will see the context very soon. So I am going to talk to you about odontoid process in a little bit lateral manner, not in the straightforward thinking process. And let me see if I'm able to give you this perspective. Odontoid process is a bone which is like a very sharp tooth. And this tooth, every spine surgeon is worried about. This is the sharp tooth, odontoid process. And this invaginates into the brainstem and cervicomedullary neural structures And the entire craniovertebral junction philosophy is based on this concept that this intruder, this sharp tooth, should be removed. Otherwise, it will be a big problem for the patient. So as we said that there was no need to remove this tooth, you can realign this and bring it back to the normal situation. So it is always better to have your teeth intact rather than removing your teeth. Odontoid is also called dents or tooth. So this was the concept, and the main issue is this tooth is the main troublemaker for a lot of spinal pathology. And I must also tell you that atlantoaxial instability is not only misunderstood, it is understood. And without any doubt, undertreated clinical entity in the subject of spine. So this compression of the odontoid process has been the troublemonger and troublemaker for a long period of time. And removal of this odontoid tip has been the treatment. Os odontoideum has been considered to be a very bad kind of a pathology, which leads to atlantoaxial instability. So this has been considered to be a great pathological phenomenon, which leads to an unstable atlantoaxial joint, meriting the need for fixation. Basilar invagination in general is a phenomena where odontoid process goes inside the neural structures.
Okay, there may be a halt in this internet service as usual, so just hang in there. He usually comes back, and it's usually about this time, matter of fact.
It's remarkable how accurate that.
Yeah, the outage is, yeah. He usually predicts it.
Yeah, John.
Oh, there we go.
John, I am a little bit troubled by these frequent breaks. So what I will do is maybe, let us see, John. So basilar invagination as an entire concept is based on how to treat this invagination of the odontoid process in this group and how to treat tonsillar herniation in this group. So I was doing transoral surgery for a long time, and my number of cases were going in hundreds. And every year I was demonstrating in this part of the country and that part of the country and various places. And
Hang in there.
okay, John.
Okay, very good.
John, what my problem is, I'm working from home
Right.
and I'm not getting a good internet connection. Maybe I can give some days break and come back when I'm able to transmit my lectures from my department after this lockdown business gets over. So let me think about it. Okay. So essentially, this odontoid tip has been the issue, and odontoid process has been considered to be a very, very nasty or notorious bone. So this is another thing that we had started introducing these metal implants, and then I had removed the entire iliac crest and introduced in this area. So I was doing a lot of transoral surgery, and after transoral surgery, whether fixation is necessary or not, ultimately now we have come to a conclusion that transoral surgery is a very historical kind of a situation. Now, what about odontoid process? And my title says that it is not an ordinary bone. It is an absolutely divine structure of the body. So this is the craniovertebral junction, and odontoid process is stuck right in the middle. This craniovertebral junction, this is the atlas bone, this is the large lateral transverse processes from front. This is the center for mobility, and craniovertebral junction is the center for stability of the most stable and most mobile structure of the body. Now, there is no disc in this region. If you see the literature, and if you have seen my previous presentation, I was saying that disc is the most mobile and most stable entity of the body. It gives stability and mobility and shape to the spine. But there is no disc here. So what is the answer? Why there is no disc? And what is the function of how the function of the disc has been taken over in this most mobile junction and most stable junction? So we had introduced this concept that odontoid process is actually a replica of the disc. Odontoid process takes over the function of the disc. If you see, there is not a single muscle attached directly to the odontoid process, and anterior in this area, not a single muscle attached. Similar to not a single muscle attached to the disc. So I will like to elaborate on what I am saying. So this is the beautiful craniovertebral junction, odontoid process right in the middle of activity. There are various pulleys attached here, pulleys attached here, pulleys attached. Pulleys means muscles, muscles attached to the spinous process, to the transverse process, various muscles attached to in the vicinity, nothing attached to the odontoid tip, nothing attached in the front, everything is from behind. So to introduce this concept for the first time in the literature, I am going back into the embryogenesis and going back into the craniovertebral junction of various animals. And first animal that I'm introducing to you is a horse. The horse is a very strong muscular body. All the muscles are located lateral. Craniovertebral junction is very strong. The movements of the neck are very, very strong. In human being, the movements of the craniovertebral junction are 70 degrees, but here it is almost 120 degrees rotation of the neck. So how is the craniovertebral junction different in a horse than in a human being? So this is the dissection, not dissection, these are the bones that of the craniovertebral junction of a horse. Now you see the beauty of this, beauty, you just enjoy the beauty which I'm showing you. This is the C2 spinous process, which is quite huge, as you can see. This is the C1 arch. You see the beauty of this arch. This is the C1. You see quite a deep facet for the condyle of the occipital bone, very deep condyle. And in this C1, the facet of C1 is almost completely taking complete circumferential. You see the facet of C1? And the transverse process of C1 is quite huge to take care of muscle attachment, quite strong muscle attachment. This is the C2. You see the quite a large spinous process of the C2. You see the facet of C1, the articular, this is C2, this is the odontoid process. You just see the odontoid process in its divinity. This is the C2, this is C2, this is C2. This is the articular surface for C1. This C1 articular surface is quite flat. This occipital articular surface is quite deep. So C1 and C2 articular surfaces are relatively small and quite flat. This is the odontoid process. You see the beauty of the odontoid process like this. And you see the deep attachment points for the ligaments. So this odontoid process is a signature odontoid process of herbivorous animals. I will show you more. So this is the beauty of the horse, but you have not realized the beauty of the craniovertebral junction ever. This is the beauty of a deer. You see the deer? I know it is very difficult for you to understand, but I will show you some beauties here. This is the C2, and you see the odontoid process. You see the odontoid process of the C2 almost like a circle. And atlantoaxial joint is quite large in a deer. The eyes are also placed laterally in a deer, allowing lot of lateral movement. The movement of the head of the deer is almost 170 degrees movement is possible at this joint. So if you see this, this is the C1 and this is the C2, and you see the odontoid process, and you see the articular surface of the odontoid process, atlantoaxial articulation coming anteriorly. You see the joint is not only lateral, but it is anterior, almost in a pattern of a semicircle. I hope you are getting to the point which I'm showing. This odontoid process is a signature odontoid process of herbivorous animals. The neck movement is quite big. It is not so much so in carnivorous animals. This is the posterior surface of the arch of atlas, on which huge muscle attachments are there. The transverse process is quite big. This almost includes the transverse process. This is the spinous process of the C2 and large transverse process of the C2 vertebra. The main issue which I'm trying to discuss today is the issue of the odontoid process, which is a signature odontoid. Before I go to odontoid, I want to show you. Well, I'm not able. Okay. So this is the groove for the vertebral artery. I wanted to show you. I'm not able to go back. So now comes the king lion. King lion is the most handsome animal on the entire planet. You see the fantastic handsomeness. You see the face, quite a wide face at this point. And also the wideness of the ligaments. You see the wide transverse. This is the C1. This is the superior surface of C1. This is the groove for the vertebral artery. Large, flat transverse process to give attachment to the huge muscles that are attached here. More importantly, I am showing you the odontoid process. This is a signature odontoid process of a carnivorous animal. You see the large spinous process giving attachment to very strong muscles. This is the vertebral artery groove and a relatively small articular surface for C1. Odontoid process is like a peg or a dents, like in human beings. So what I say is, by development, human beings are carnivorous. So this is the fantastic, strong muscles and strong bones of a lion, king lion. And odontoid process is like a peg. And this is the groove for the vertebral artery. This is the groove for the vertebral artery. It goes in, then turns here, and then goes here. They're very fantastic. And if you see the beauty of the skull of a lion is this incisor muscle. If you see this muscle, which has the capacity to break the human skull into small little pieces, this incisor goes right, this is the orbital wall, it goes right in the orbit. And this is the zygomatic arch, and the temporalis muscle is having steel-like ligaments. The majority of muscle is white, steel-like ligaments, which help in this biting process by this incisor muscle. And you see the occipital notch, much huge and bigger, giving attachment to the suboccipital, strong suboccipital muscles. So that is the beauty of the odontoid process in carnivorous animals and in herbivorous animals. And I'm showing you just two, and it is uniform. You see the bones of a dog are like human being. The bones of a goat are like a herbivorous animals. So size-wise, if you see the size, this is the human bones, this is the bone of a deer, this is the bone of a horse, and this is the bones of the lion. Now I want to show you the beautiful bird, beautiful. And if you realize the bones of this neck of the bird has the power to move circumferentially, 180 degrees. I want to warn the viewers that about 6:20, my internet breaks for about 7 minutes. So please bear with me at that time. So this king or queen bird has a power to move his or her neck almost circumferentially. How on earth can the neck move circumferentially? So there are some special characters in the craniovertebral junction which allow it to move circumferentially. So this is the ring of C1. And if you see the ring of the C1 ring has one body. And this body has a direct attachment to one condyle. So there is one body and one condyle. There are no two lateral masses or two articular surfaces. There is one condyle and one body. And you see the odontoid process here. of C2 in a form of a latch. And on this one body, there is the possibility of circumferential movement in this beautiful animal. Now I come to odontoid bone. So a lot of articles, a huge number of articles have been there written about odontoid process. And one beautiful article I wrote on odontoid process, and this is my odontoid process fracture article. So you may not know, and you may not have seen, many of you have certainly not seen this kind of a rickshaw. This poor man is driving this rickshaw, sometimes with very heavy load. And this rickshaw he can run very furiously with this rickshaw. So in my beautiful article here, this article I had written, and if you can read this, such rickshaws are now sometimes seen in Kolkata, in one big Indian city. Now this man sometimes holds kilograms and very heavy loads. So what I had said in my article, that this rickshaw man, this rickshaw puller, is like odontoid process. He's not like a huge elephant or a huge strong man. He is not a power of this rickshaw. He's only the brain of this rickshaw. The design of this rickshaw, the wheels of this rickshaw, and this handle of this rickshaw makes the rickshaw carry very heavy weight. It is this brain, this rickshaw puller. Nobody has the strength in the world to hold 500 kilograms and run. Nobody is that kind of a strong man. No Olympic strongman has ever been able to lift more than 300 kilograms of weight in even Olympics. No Olympian has ever been able to lift more than 250 kilograms in hand. So this poor man is not an Olympian or any kind of a abnormal kind of an animal. He's a very normal human being. And this design of the rickshaw makes him run. And he just have to hold and direct the rickshaw. So that is my philosophy, that this rickshaw is just the brain of the entire movement. The brawn or the muscles are provided by the design of the rickshaw. And this rickshaw puller is like the human disc. Disc has no muscles attached to the disc, but it is able to conduct the entire activity without moving any muscle.
Okay, we may have come to that break that Dr. Goel was referring to, so just hang in there and be patient. He usually comes back. Grab your tea or coffee. I'm going to eat some donuts. Feel free to take a stack.
John,
Very good. You're back. Carry on. Carry on.
do you think some people are still there?
Oh, yeah. There's a lot of people here.
Okay.
We don't want to leave.
Okay. So now I'll come back. I hope there will be no further interruptions. So like this opera conductor, you see this opera conductor is not having any instrument in his hand, but he conducts the entire opera. And without this opera conductor, there will be no opera. So he's the brain of the opera. Maybe he's not actively involved in instrument handling and instrument, but he's the brain. Similarly, this fellow is the brain of the movement. And without this guy, the rickshaw will not be able to take direction or turn this side or that side and go from one destination to other destination. He's the brain. And I relate him like odontoid process. And I relate this gentleman like odontoid, beautiful odontoid process. And this odontoid process is like a disc. Disc is odontoid process in a similar location without any muscle attachment, without any direct activity, but it regulates the entire activity from birth till death. So this is divine. This odontoid process is the brain, is divine. Like the disc, which is divine. All the activity is being conducted from the muscles and are actively pursued by in the region of the facets. but it is originated and coordinated and conducted by the disc in the spine and odontoid process in the head. All the muscles are behind. They are acting with their focus on the spinous process, on the transverse process, and ultimately the fulcrum of the pulley is the facets. These are the facets, these are the muscles. This is the pulley. In this scheme of things, there is no odontoid process, there is no disc. This activity is going on, being conducted by the musicians, being regulated by the odontoid process, and the disc is divine. So there are various muscles and ligaments circumvent around. You see, there is a small articulation here, which this on the back side of the odontoid process, and in the front of the odontoid process, there is an articulation. But basically, there is not a single direct activity being conducted by this. These threads are like these kind of instruments which the opera conductor is holding. So there are various muscles attached behind, lateral, and this kind of. Basically, the activity is conducted at the region of the facial articulation. So if you have to stop any activity, if you have to stop the activity, if there is some inactivity or some malactivity is going on, nothing, this divine structure has nothing to do with that. All the ill activities and malactivities are being conducted at the facetal articulation by the muscles. So my concept is very clear. My concept is these muscles, all the muscles are focused at the facets. And if you do not take care of the muscles, misuse, disuse, abuse, or injury of the muscles will focus on the facets, making facetal instability an issue. And this divine structure has nothing to do with this issue of instability. All the muscles are behind. So when there is odontoid fracture, now you will ask me what to do when there is odontoid fracture. And this is my article which I had recently written on odontoid fracture. What to do when odontoid is fractured. So there is a very common treatment of introducing a screw from front into the odontoid process. It is like treating God. My concept is, if a God is sitting in a temple, and if the God itself is damaged completely, you cannot repair the God. You can maybe make a new temple for him. So there are various types of classification. If you want to go in detail into what are these classifications of mine, you must go through this article. I will again give you that reference from World Neurosurgery, recently written article on my experience with 124 cases. So when there is a fracture of odontoid process, if you have to stabilize, the main issue is, when do you have to treat this? You have to treat when you find that the atlantoaxial joint is unstable. And when you find that the atlantoaxial joint is unstable, you have to stabilize the atlantoaxial joint in the best possible fashion. And that best possible fashion is from behind lateral mass plate and screw fixation, or rod and screw fixation. That is the best, and realign the craniovertebral junction if it is possible. When there is a fracture of the odontoid process, and whenever you see that there is a possibility of instability, There are various parameters to assess the possibility of instability. You fuse the atlantoaxial joint, and this is delayed after several years of fusion. Essentially, when you think the joint is unstable, you need to treat this. And when you think it is not unstable, or it can be stabilized by halo fixation for a period of time, that is a possibility. But whenever you have to treat in a final manner, not in a semi-final kind of manner. And in a delayed kind of fashion, there can be self-restoration or self-fusion which can happen. But if there is a possibility of instability, you treat it by stabilization. So that is my concept in situations of atlantoaxial instability following odontoid fractures. You stabilize the atlantoaxial joint, and you don't do any half-hearted kind of screw fixation here or screw fixation there. If you think it can stabilize by one screw, maybe it is your option. But my strategy is, whenever instability is considered to be a possibility, you stabilized by the best possible treatment fashion, and that is lateral mass plate and screw fixation. So there are several cases of mine over several years. Lateral mass fixation, I used to do anterior treatment once upon a time, but now for a long period of time, only lateral mass fixation is the treatment for odontoid fractures. And that treatment comes into play when you think that atlantoaxial instability is the problem. Now, other very beautiful issue which I want to discuss with you is the issue of os odontoideum. And this also I have recently published, and you must see my article on this subject, where I mention in this article, and you must read between the lines, that odontoid process is a divine structure. Os odontoideum is not an embryological issue or a problem I mention in this article. I say that os odontoideum is a natural protective maneuvering by God. Now, what is this natural maneuvering? I will like to show you. So this os odontoideum you have seen on several occasions. And when you see this os odontoideum, you think that there is a problem here, and there is an unstable spine, and you need odontoid process is pathological, and this certainly needs stabilization. So this is the concept. I must say that this concept, that this os odontoideum is an indicator of atlantoaxial instability, and it needs atlantoaxial stabilization. It looks very simple, but if you read the literature, this concept is not at all clear in the literature. There are many people in the world still preferring to do transoral decompression, and there are several people in the world today who are preferring to do occipitocervical fixation for this entity, which is completely, in my estimation, a negative kind of operation. Decompression from the front and occipitocervical are completely negative operation. This is not a pathological phenomena. This is a divine intervention, indicator of atlantoaxial instability, and indication of the need for atlantoaxial stabilization. I will like to show you some more cases. So when you see this os odontoideum, you immediately think that this is a pathological problem, an embryological disturbance, and this gives rise to atlantoaxial instability. So this is primary, and instability is secondary, and stabilization is the treatment, atlantoaxial. Of course, the literature still says occipitocervical stabilization and transoral decompression. The issue is clear in the literature that this is pathological and gives rise to atlantoaxial instability. So this is one of my more beautiful articles, which of course I cannot repeat it, If you want to see this and see these divine interventions, you have to read this beautiful article. When there is atlantoaxial instability, there are lots of divine things happening. Divine majesty. The glory of God is to conceal a thing, but the glory of the king is to find it out. So God is concealing the facts and glory of us neurosurgeons. If we think we are kings, we cannot ever think we are gods, but we can certainly think we are kings. But we should always remember that we are quite innocent and we are children in front of this divine majesty. And we should at least make an attempt to think about the games the gods play when there is atlantoaxial instability and how the natural reparative mechanisms come into play. So as I had shown you this article, atlantoaxial dislocation there are various musculoskeletal abnormalities which are reversed on stabilization. So there, this torticollis, short neck, I had introduced to you the other day, short head, short spine, torticollis. This can be reversed immediately after you do atlantoaxial fusion, fixation. So these are not abnormality. These torticollis and short necks and short head and short spine are not abnormality. They are natural reparative mechanisms. They are protective mechanisms. Similarly, I had said that cervical fusion is a protective mechanism of the body. Bifid is a protective mechanism of the body. These are not abnormal mechanism or these are not pathological phenomena. They come into play when there is atlantoaxial instability. So these bone fusions and bifid are not embryological problems. They are games that gods play. They are divine games. Basilar invagination, syringomyelia, Chiari formation are not pathological or embryological dysgenesis, but they are divine plays when there is a phenomena called atlantoaxial instability, which is a man-made phenomenon. If you are not taking care of your muscles of the back, if you are injuring your muscles, then there comes a phenomena of atlantoaxial instability. Remember, just imagine a situation, there is sudden car accident and you have broken your spine, there is atlantoaxial instability. You touch your occipital muscles, they will be under such huge spasm that this spasm is like rock. And this rock-like spasm is a protective mechanism of the body. Similarly, in chronic protective situation, the neck muscles are under spasm and basilar invagination, musculoskeletal abnormalities, syringomyelia, and Chiari formation are secondary divine intervention. So I had said, and I have shown you the other day, that syringomyelia is not harmful. Syringomyelia is protective mechanism. Chiari formation is a protective mechanism. So I am repeating this again and again in my several lectures for a small group of people who are sitting in front of me and wanting to hear me. But if you are hearing and if you are understanding, I will suggest you please go and read some of these articles which are saying that atlantoaxial instability is the primary problem. Fusions, assimilation of atlas, C2-3 fusion are protective mechanisms. So now come to our question. Os odontoideum is very frequently associated with bifid arch of atlas. It is very frequently associated with C2-3 fusion. And I am introducing to this concept that this odontoid process breaks itself. Suppose this odontoid process had not broken, and it was up till here, it would have clearly, you see, this odontoid tip has naturally broken. This odontoid process, if you have seen the tail of a lizard, and if a cat comes and catches hold of the lizard, it gives away its tail. Similarly, God gives away this odontoid process and it protects the cord. And many of these os-odontoid patients, there will be severe cord compression and the symptoms are quite marginal. Imagine if this odontoid process was intact, it could have completely transected the cord. So bifid, presence of bifid, presence of C2-3 fusion, presence of os odontoidium are divine interventions. Now you see this. This is os odontoidium. Suppose this os was stuck here, the cord would have completely transected. You see the bifid, there is no, imagine if the posterior arch of the atlas was intact and the os odontoidium was intact, there would have been no space for the cord. And this patient, I must tell you, ladies and gentlemen, sitting here, has come to me with very marginal symptoms because of the divine intervention of bifiding of arch and introduction of os odontoidium or breaking of the odontoidium os and bringing it in front in a very non-specific kind of location. But this formation is an indicator of an unstable atlantoaxial joint meriting the need for fixation. And this, once you fix, the fusion of this area will automatically come and the bifid will not remain bifid. This, I had told you that this retroodontoid cyst formation is also a natural protective mechanism. You do, and a cushioning of the cord, you do fix from behind. Chiari malformation is cushioning from behind. This is cushioning from front. And you do fixation, this cushioning is no longer necessary. Degeneration of the craniovertebral junction is a very common clinical entity, never discussed in the literature. My article in 2010 was amongst the first articles on this subject, where we had discussed about degeneration of the spine and ossification in the paraodontoid and region, presence of osteophytes, presence of buckling of ligaments, reduction of the disc space are divine intervention indicators of atlantoaxial instability, meriting the need for stabilization. Ossification in the apical ligament is not os odontoidium. It is a natural protective maneuvering. See the ossification here, see the ossification here. These are all indicators of a divine phenomena, divine protective mechanisms, which are telling us that there is some problem in the joint. You please take care of the problem in the joint and fix the problem. Don't disturb me. This is not to be disturbed, my dear friends. This is an indicator to human eyes that atlantoaxial joint is unstable. This kind of abnormal ossification here, you must see when you are seeing the image. These are indicating that the atlantoaxial joint is unstable, and there is, and this instability is not by this instability is by you and by me, because we have not taken care of our muscles. There can be multi-level spinal instability and atlantoaxial instability. You treat by stabilization, not by decompression. Decompression is certainly a negative treatment. You see this artificial bone formation. Osteophytes are indicators of an unstable atlantoaxial joint, an unstable spine. Decompression is not the treatment. Stabilization is the treatment. This, when you see this compression, don't suddenly start jumping on the bones. Don't suddenly start jumping and killing the odontoid process. You stabilize the joint, and then after 2-3 months, when the fusion has occurred, ask this gentleman to do extensive exercises, and he will be all right. Presence of posterior longitudinal ligament thickening, presence of osteophytes, presence of bone abnormal. Don't call this abnormal bone. This is divine intervention. Don't call this bone, posterior longitudinal ligament ossification, abnormal. These are divine intervention, which tells you that there is an unstable craniovertebral junction. This posterior longitudinal ligament is not abnormal. Don't start breaking it and removing it. Don't start removing the odontoid process. These are indicators of atlantoaxial instability and indicators of the need for stabilization. This is not a pseudo tumor. This is osteophyte formation, which is an indicator of need for atlantoaxial stabilization. So I'm showing you some of these beautiful articles. This is not abnormal. This is cushion from front, Chiari is cushion from behind, indicators that stabilization is the treatment. Pannus it is not a pathological phenomena. It is buckling of the posterior longitudinal ligament. So whatever is inside the odontoid, whatever is outside the odontoid is the game of God, is the game of nature. It indicates to you an unstable phenomena. It indicates to you the potential vertical spinal instability, which is the cause of problem not only of atlantoaxial joint, but the entire spinal spondylotic disease is an issue of vertical spinal stabilization is the issue. So my recommendations for you will be exercise and keep your muscles strong. Particularly this COVID time is a good time to exercise your muscles. Don't injure your muscles by accident. Do not blame your disc or your odontoid process ever. There is no terror of error in nature, my dear friends. Thank you very much.
Okay, very good. Thank you very much, Dr. Goel. And we have a lot of panelists here, and I'm sure.
Okay. Now, can you get me out of this? And can you get
sure. Yeah, sure. Let me get you out right now. Okay, the floor is open for comments or questions with Dr. Goel.
Now, before the comments are open, I will again like to ask the panelists. Say yes if you think there is some divinity there, and say no, that this is all useless. This is game of, please say yes or no. I want to see that on your chat box. You can go to your chat box and say yes or no. I want to see how many people are saying yes and how many people are saying no. If there is any doubt, please say no.
Okay, overwhelming. Just like I thought, people just aren't leaving during these delays. They're just not leaving, Dr. Goel. So let's continue. Let's just continue.
So you can see that, John, divine.
Yeah.
God is present.
Well, people
and
are
God
staying
is
here.
there.
People are staying.
You see, that is why if we are, we can, God will help us get over this COVID, this virus. You just pray to God and don't start removing unnecessary, we have to. So so John, you see, I am thankful to all the panelists and
It's overwhelming. Yeah. So you can continue with no delay.
So that is and if there are some questions now, John, I will be happy to answer.
Good. Okay. Okay, step forward, people with comments or questions. Don't be afraid. This is a platform for interactivity.
Hi, Professor Goel. Thank you very much. That was a Beautiful, beautiful. It's these are not very common talks. The stuff you're showing is it takes you out of your comfort zone, and unless you're like I think what you mentioned before, you have to be mentally supple to listen and have the humility to at least take that first step forward. And I think that's what all the panelists are highlighting here. My question is, when you have people that have come back to you from, if someone has done a Chiari decompression, a C1 laminectomy, do you still propose the C1, C2, or do you, in that case, make an exception to go to the occiput, or will that provide enough stability if it's already been done before?
Yes, Abhilash, let me answer that question. You see, when there is a decompression done, it is, you know, there is no question, Abhilash, there is no question absolutely that it is a wrong operation. Now I have got an experience of hundreds of patients. The problem is, you know, what is the problem? The problem is that to do C1, C2 fixation in presence of Chiari formation and presence of syringomyelia is quite a difficult operation. It's not an easy operation because the venous congestion in that area is quite huge in that situation. Now, if there is a decompression done, now I have got a very big series of patients who have already undergone decompression. And I recommend C1, C2 fixation with a new introduction of new life. I say, you know, you will be surprised when the patient comes to my clinic after the operation. You know what is my question? You answer yes or no. Have you got a new life? You say yes, I have got a new life. Or you say I have not got a new life. My question is new life. So that is and C1, C2 occipital bone is a historical operation. I never include occipital bone ever. And you know, Abhilash, in the entire US, in the whole country of US, there is not a single person in US who is doing C1, C2 fixation. Very, very few people. And I'm sorry to say this, but this is a fact and you know it. And this, you know, the problem is, the question is, they are not ready to listen to, you know, agree that there is some divinity in nature's powers. There is so much technicality and technology that they are not ready to listen. And when my article was published in Journal of Neurosurgery, there were huge comments on what is this and this and this, we are doing See, I am not trying to blame anybody. Abhilash, you must understand, I am not here to criticize anybody. I am not here to blame anybody. I am just giving you my perspective, and I am giving you my huge experience on this subject, showing you several if I'm not sure if you attended my lecture that on Chiari formation, which I gave for 2.5 hours, with several cases and several cases with syringomyelia. I don't know how to prove this point. If you have some advice for me as to how I can prove this point, you please let me know, Abhilash, because you are in that system.
Yeah, I mean, I think what you're bringing up as an important point is that you're ultimately a victim of your training. That is the bottom line. Where you train makes a huge difference. So these venues really open, you have to open your eyes and be willing to listen to other countries, irrespective of, it's not a...
Now, another issue, Abhilash, another issue too for you and for many people in US. You have seen this os odontoideum. You have seen this small presentation.
Yes.
100% of people in US, 100% are doing occipito-cervical for this. And 80% of people are doing transoral decompression for this, which in my estimate is an absolute uneducated form of treatment. Now I'm using very harsh words for this, but this is a very close kind of community, which is, you know, I hope this lecture goes and what my feeling goes to others. But 100% of people in US still are doing occipito-cervical fixation for os odontoideum, 100%, not 98%. So this is the issue. Now, I have given my series of 198 cases of os odontoideum I have recently published in World Neurosurgery. I hope there is some change in the world. I hope, but I'm not sure. because the concepts are that nothing can come from a country, from a slum hospital from India. Nothing can come new. That is the concept. I hope you can change this, Abhilash, for this understanding and this egoistic kind of feeling.
Yeah, your passion is resonates very well, and I think it's not a it's awesome. You're extremely inspiring, and thank you so much for taking your time out of your busy schedule to teach all of us.
Thank you, Abhilash. Thank you. Is there any other question?
Yes, Professor Goel, I'm truly an admirer of your passion, your 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 decision and your move to stay out of the line, no matter whose ox is God, because you've made salient points here, and it takes somebody with a soft mind to open up and then absorb a few things and then not think straight, think wide. People have been trained to believe that one way is the best, and they try to impose that on other people. And most of the times that is what happens. And your statement about what happens in developing countries versus developed countries is evident. That times we present new ideas and even the abstract is not accepted because they think someone coming from this and that region, what do they have to offer? It does not make sense in the ideology of global neurosurgery, where a certain group of people are still isolated. But sincerely, I admire you because my trainer, who is retired now, used to think just the same way you folks, permit me to use the title, old schools, used to think, and it makes it broad. You are someone that is well-rounded, not subspecialty. You are able to take on anything and that's the kind of training we were given before branching out.
Thank you so much.
I really
Nice
appreciate
of
it.
you. Thank you.
John? Go ahead, more comments, questions?
Maybe there is only yes, there is no other comment.
Oh, just wait a second. I'm sure people will get less shy and less shy with this tech. It's just so new to everybody. I think most people taking the leap. Okay. I usually threaten I'm going to sing unless someone asks a question. Adnan, do you have any comments or questions for Dr. Goel? You there, Adnan? There you go. Go ahead, Adnan. Oh, perhaps his audio is not working correctly. Let me see here. What else we have here that I can pick on? Let's see. Okay.
Okay, John. Is there
Okay.
anything?
Yeah, anybody else? Come on, look, you guys, Dr. Goel. There's a chance to interact with them. Come on, take your chance. But okay, I guess people are being a little more hesitant today than normal. So, okay, Doc, I guess we'll see you tomorrow. The overwhelming opinion is that they'll take the tech slowdowns just to be in the same room with you. So,
Thank you. Thank you so much. Thank you, John. Bye-bye.
okay, see you tomorrow.
Bye-bye. Yep. Bye-bye.
Okay, very good. Yes. Vlad, are you there? Is that you? I didn't see your name there.
I am here.
Oh, I would have
Listening, I enjoyed that, you know.
I would have picked on you if I knew you were there.
There was hardly anything to add to what Atul said, you know. It was Excellent.
How have you been? Where are you at now?
Good.
Are you home? Are you home?
Home.
Oh, okay.
Home. We have a holiday today.
Oh, in
1st
Czechoslovakia.
of May.
Oh, really?
Yeah,
Oh,
working
1st
day.
of May.
1st
Is it?
of May.
Oh,
Exactly.
okay. Very good. So I guess you've been presenting everywhere, right?
Right. Several times. I've got something scheduled with you on Sunday, I guess.
Great.
Okay. Hope it will work.
Great. Yeah, let's see here. Dung, are you there? You want to say hello, Dung? See, he's a Nigerian. We're getting a lot of Africans, Vlad. It's good to see. Oh, there you are. I want to introduce you to Vlad. Vlad.
Is it any better now?
Yeah, there you are. You
Yeah.
get to meet a big neurosurgeon, Dung.
I've been here nearly all the time.
Okay, yeah,
Not
yes,
all,
you didn't have your picture on. Well, anyways,
Yeah.
Dung is a Nigerian resident in neurosurgery. Are you there, Dung?
Yes, I am.
You're outside somewhere.
Good day, Dr. Benz.
Good day. Are
It's
you
a pleasure to
outside?
meet you, sir.
Or is it
No,
just
no,
the
I'm not.
background?
Yeah, it's a virtual background. It's a pleasure
Good.
to meet you, sir. I think you were in Nigeria 2 years ago for CANS conference. I
Yeah.
remember.
Right.
Yeah.
Right.
Yeah, we had a great session with you.
Yeah, it was a great time.
Yeah, we did. And it's a
Yeah.
pleasure to meet you here, sir.
Hopefully we shall travel again.
Yeah.
Yeah. Much better in person than like this.
You see, Vlad does not have a background. That's a real background.
Yeah,
And he
yeah.
assures
That's
me, he assures me he's read all those books.
Yeah. It's my den.
It's not just decoration, right?
Dr. Benz, nice to see you here.
Nice to see you too.
Oh, it's another
You are
Nigerian.
already still. You should be moving a bit.
Yeah, we were in Cannes together. Yeah, in Abuja.
Yeah.
He's also from Nigeria. Okay. So, okay, we'll end this.
Yes, I think he's having some challenges
thanks.
with the audio.
I've got to go. Thanks everybody for coming. And
Thank you,
Vlad,
Dr.
we'll
Bennett.
see you Sunday, Vlad.
Hope to see you.
Okay.